But the first things we're going to talk about are basic concepts that you're going to have to participate in when you are working on a unit in the hospital. Okay? And the first thing is quality improvement. Now, there are There are QI committees. Have you seen QI committees where you work? There are QI committees, and their goal is to make sure that the processes that go on in the hospital are geared to improving patient outcomes. Okay? It's all about outcomes. There was a report, a study that was conducted by the Institute of Medicine, and it was released in the year 2000, but we still refer back to it because it was very much a landmark study. It changed the way that people looked at healthcare. And this is the report. The name of it was "To Err is Human: Building a Safer Health System." That was the name of the report. Do you agree with that? To err is human? Yeah. The problem is that when you're dealing with someone's life, erring can cause death. And that's one thing that they focused on. This is what they found in that report, and I thought it was pretty eye-opening, that as many as 98,000 deaths in hospitals each year result from preventable medical mistakes. 98,000 deaths each year in hospitals result in something that could have been prevented. That's pretty sad. These errors cost between $17 and $29 billion every year. Our mistakes cost between $17 and $29 billion every year. Many errors are caused by faulty systems, are caused by faulty processes, or conditions that lead people to make mistakes. What can you think of that might be that? What would be an example?
Alarms that don't work right.
Alarms that don't work properly. That's a good example. What else? Mislabeling. Mislabeling something. Okay. Healthcare is a decade behind many other high-risk industries in ensuring basic safety. We are 10 years behind other industries in ensuring basic safety. And that's scary because we are the ones that are dealing with lives. And if we are a decade behind other industries, what does that say about us? So, quality improvement is very, very important. So they came up with some aims, some goals for improving the healthcare system after that report came out. So it focused on the fact that this was a system, the healthcare system was in need of a major overhaul. It was in need of a major repair. Okay? And the thing about healthcare is that it is difficult to keep up with changing times. You can be practicing for 5 years and things will look dramatically different than when you graduate in just 5 years because it's ever-changing. Technology is growing, and that's one thing about nursing. When you graduate, you have to keep up with your continuing education. You have to see what's going on in the world. Okay? So, what they came up with were 6 aims for improving the healthcare system. Okay? The first thing was being safe. Being safe. And what was safe? They said that making sure or ensuring that the healthcare system was safe meant that you avoided injuries to patients. You avoid injuries to patients from the care that is intended to help them. Okay? So you're safe. You avoid injuries to patients from the care that is intended to help them. Okay. The next aim or the next goal that they came up with was being effective, making sure that the healthcare system was effective. Being effective means to provide services to those who can benefit, provide services to those who can benefit, and refrain from providing services to those who don't need it. Refrain from providing services to those who don't need it. Making sure that the healthcare system is patient-centered. Making sure that the healthcare system is patient-centered. So making sure that the care is focused on the patient. That the care is focused on the patient. Making sure that healthcare is administered timely. Making sure that it's timely. One of the big things that came out of that was reducing wait times in the emergency room. And how many of you have seen on the billboards as we go down the highway, they've even got the times listed on the billboards. Have you seen that? You could go on the computer. You know, if you have to go to Northeast ER, you could go to the computer and see how long it's going to take for you to be in the emergency room. So making sure that the care that they receive is timely, that they don't have to wait. Making sure that healthcare is efficient so that you're reducing waste, you're avoiding waste. Much of the cost of healthcare comes from the fact that we waste a lot of supplies. We waste a lot of things that increase the cost of healthcare. And then making sure that healthcare is equitable. Making sure that healthcare is equitable. Making sure that you give equal care for all people. Making sure that you give equal care for all people. As a general med-surg nurse, and that's what we are training you to be, even though there's a lot of you who want to be other things. Some of you don't know what you want to be when you grow up, and that's okay. An associate degree, a community college program, is training you to be a general med-surg nurse. And so when you get out there, you're going to be expected to know some certain things according to improve the healthcare system. You are going to be expected to be able to identify indicators to monitor quality and effectiveness of the care that you give. Identify indicators to monitor quality and effectiveness of the care that you give. One of the things that they're doing right now in the hospital, they're doing IV QI checks. So they have certain people on the units who are designated to go around and see, are people labeling the tubing? Are people labeling the dressing that goes on the IV? Those are indicators to let us know whether or not we're doing our job effectively. You are going to be expected to be able to assess and evaluate the data that comes out of these studies. You are going to be able or expected to assess and evaluate the data that comes out of those studies. You're going to be expected to recommend ways to improve care processes. That's part of what you're doing with these projects. You're recommending things, or you're teaching your nurses how to do certain things to make sure that they give quality health care. So you're recommending ways to improve your care process. And then lastly, you're going to be expected to implement activities to improve care process. So you're going to be expected to do whatever comes out of the studies. If it says that doing mouth care every 8 hours on a ventilator patient is the way we should go, then you're going to be expected to do that. You're going to be expected to implement those activities. What's that called? There's an evidence-based practice, and I know you've heard that over and over and over and over and over. But it's the truth. Why do we do what we do? Well, because somebody tried it sometime and found that there was a better way to do it. Okay? Have you seen lately that I don't know if you've noticed this or not, but they're pushing the foaming still, but they've gone back to saying hand washing really is the better way to do it. Have you noticed that? Okay. So now, yes, you have to foam, but hand washing is the goal. You know, used to it was okay if you didn't hand wash, as long as you foamed. Now it's not. So they do those studies, nurses do those studies, and we make sure that the care that we give is good. Okay, so how do we collect the data? There is a cycle. It's called Plan, Do, Study, Act. Plan, Do, Study, Act. Okay. The plan part of it means that you want to develop a plan to change. Okay? Develop a plan to change. So you've seen the problem, you've noticed that there's an issue. Now I've got to develop a plan to tell my nurses on my unit that, you know what, I've noticed that this is not a great way to, collect vital signs. This is how we're going to do it. This is when we're going to do it at a different time. Okay? The do part of it is that you're going to implement the change. So you've planned the change, now you're going to implement the change. Okay? The next part of it, the study part of it, is you're going to summarize the results. What happened when you did this? What happened when you implemented this change? Was it successful? Was it a big old flop? Did people hate it? Did nobody do it? And then the act part is to determine what changes are required. What does that sound like? It sounds like the nursing process, doesn't it? It sounds like the nursing process. We've evaluated it. We've seen if it's, the evaluation part of the nursing process. We've seen whether or not it's good or not. If it's not, then we go back and we change it. We reevaluate it. An example. About a year ago, well, it might have been a little bit more than a year ago, they decided on PEDS, and probably throughout other units too, that bedside reporting was the way to go. Okay, so every nurse had, and you had not only report at the bedside, but you had to go in the room and report on your patient in front of the patient. So I thought to myself, this is going to not be a good thing. Because, you say stuff in reports you really don't want the patient to hear. So that was implemented. They said, this is going to be great because the patients are going to be involved in their care, and that was the whole thing. You want your patients involved. Well, we implemented it. That was the change. We implemented the change, and then what we found was that for those of us who were coming on at 6:45 in the morning, those people were asleep. You don't want to wake. Let me wake you up so I can report and you can hear what I'm saying. Especially if they've been up all night with a screaming kid. They don't want to be woken up. So we had to reevaluate. We had to say, okay, we're going to report at the door. If the patient's awake, they can participate, but we're not going to go in and wake them up. We had to change. It may sound simple, but it was something that changed the way that we did things on the unit. Okay. The thought was nice, but it didn't end up the way it's supposed to be. Okay, so this whole process asks us 3 questions. There's 3 questions that we have to ask. what are we trying to accomplish? Are we trying to accomplish something that's going to be better for the patient and the unit? Or is it just something that somebody read or heard online that they thought was really great and it's just not a feasible change? So what are we really trying to accomplish here? The second thing is, how will it be assessed? Okay? How will it be assessed? There are some things that are very difficult to assess. When you go into a bachelor's program, one of the things that you're going to learn about, and you may know some of it already, the difference between quantitative data and qualitative data. Quantitative data is your numbers, your data. I don't know if you remember me telling you when you learn concept maps that when you're doing concept maps and care plans, you need to have numbers and lab values, and if you're going to say your patient's going to walk a distance, say they're going to walk 3 feet, or to have a number, because what does that make it? It makes it easier to assess. It makes it measurable, makes it easier to evaluate. Whereas qualitative data is just what somebody says to you. And it's not as easy to assess or evaluate because it's very subjective. So how are you going to do that? How are you going to assess it? And then what change is needed? The third question is, what change is needed that will result in improvement? So that's your evaluation part. What do I need to change? What do I need to do to make it better? Okay? All right. Risk management. This is another part of the hospital that you're going to see and that you may become a part of, risk management. But it involves us all. Our goal is risk reduction. Our goal is risk reduction. Okay? So it involves preventing risk when it's foreseeable. Hopefully you can see it coming and prevent it from happening, and focusing on clients with attention to outcomes. So, some examples. How do we do risk reduction? The first thing is to make sure that everybody's assessment skills are adequate on admission and throughout hospitalization. Making sure that all of your nurses understand and remember the assessment process. Okay, making sure that they have adequate assessment skills. If you can assess something, you may be able to prevent an accident from occurring. Okay? The second way to reduce risk is to provide for an early identification of problems. Provide for an early identification of problems. That's that feeling that you get when you look at a patient. You're going to get there eventually. You're going to get to the point where you can do this. When you walk in a room and look at a patient and know something's just not right. You can't put your finger on it. Something's just not right. Correcting any abnormalities. Correcting any abnormalities. Adhering to best practice standards for high-risk patients. Adhering to best practice standards for high-risk patients. An example of that is your pressure ulcer protocols, your fall protocols, restraint protocols. One thing I've noticed on my unit is that we have really gotten bad about, especially when we're really busy, not getting those hugs tags on our kids. This past weekend we had 30 kids on the unit. We were full, and we had them as outpatient days. And when you're that busy, the last thing you think about is putting a hug tag on that kid. But it's going to take, I was thinking the other day, it's going to take one child getting taken. Just one. Okay? Wouldn't hugs tags be a risk reduction measure? And you're gonna get that way. You're gonna notice when you get out there and you're gonna start cutting those corners. Okay? How many of you see nurses do that now? Yeah. How many of you have done it as a CNA? I mean, admit it. You know you have. Yeah. Everybody has. We've all cut those little corners. But when we cut corners, don't we increase the risk of something happening? You know, and back to the hugs tag, a lot of us have said, and I've heard people say it, and I thought it myself, oh, well, they've got a parent with them, their parent's not leaving. Or, oh, they're 10, they'll yell if somebody comes to steal them. You know? But that's cutting corners, and that's increasing that risk. So one thing that you really need to make sure that you don't do when you're out there is cut those corners. Okay? It's one of those things you don't do as you see me do, but do as you know you're supposed to do. When I first started teaching, I had gotten into a bad habit of, it was for being a peds nurse and not having people help me get injections. It was just me. I didn't have anybody most of the time to help me hold. So I would uncap the needle with my teeth. And then I would stick that needle in the mattress while I was trying to get my... And that was one of the hardest habits to break when I started teaching, was doing that. So, and again, that's risky because that's risky to me, isn't it? Yeah. Okay. So I'm admitting I've done it too. Conducting frequent safety rounds. Conducting frequent safety rounds is a risk reduction measure. Conducting frequent safety rounds. And then acknowledging people's demonstration of safe practice. Don't we all like to have our backs patted? Everybody likes to have their back patted. So if you see somebody doing something really good, praise them for it. Praise them for it, because that's going to continue to make them do what they're supposed to do. Okay? When we behave in risky manners, things can happen. And they are called Sentinel events. Okay? Sentinel events. The definition of Sentinel events is an unexpected occurrence involving death or serious injury or the risk thereof. So, it doesn't mean that the injury has to occur. The possibility of injury can be a sentinel event. So, some examples of a sentinel event. The unanticipated death of a patient. The unanticipated death of a patient. Discharge of an infant to the wrong family. Discharge of an infant to the wrong family. And that has happened. Babies look alike. You notice that? They all look like little wrinkled, hairy little beings. They look, a lot of them look alike. The unanticipated death of a full-term infant. The unanticipated death of a full-term infant. Rape that occurs on the facility's premise. Rape that occurs on the facility's premise. Surgery on the wrong client or the wrong body part. Surgery on the wrong client or the wrong body part. And then this is an interesting one, especially for those of you who like psych. Suicide of any client receiving care in a staffed 24-hour setting. Suicide of any client receiving care in a staffed 24-hour setting. This is the kicker. Or within 72 hours after discharge. And you think that once you've discharged them, you've wiped your hands of them. But no. Within 72 hours after discharge. Because you're supposed to have noticed. They would have to be involuntary. Yeah. Now, what do you think about this statement? This always generates a lot of discussion. Facilities are strongly encouraged to self-report all Sentinel events to Joint Commission, but they're not required to. Facilities are strongly encouraged to self-report all Sentinel events to Joint Commission, but they're not required to. Now, Joint Commission will find it when they come to make their visit. So it's one of those, do you do it now, or do you let them find it and then get in trouble? And in the meantime, what does that say about the facility that you're going to? Would you want to go to a facility that's trying to cover up something that's happened? So it really is in the best interest of all facilities to go ahead and report a Sentinel event.
So why would they make it non-mandatory?
Because they know they'll find it. It's just one of those things that you do with your children. It's better for you to tell me now than you to find out from your teacher. Like thing. Yeah. And it doesn't make much sense.
Is the fine less if they tell?
No, but it not always is a fine. It's usually a change. It may be a change in protocol or something like that. It looks better for them. And it would look better to the community. I would feel much safer going to a facility that freely admitted that something happened rather than finding out later that they covered it up. Now, you all might feel differently, but
So all that information is
public. It is public knowledge. All that information is public knowledge
How would
on the
you
Joint Commission website. See if they've admitted to it. Or they did. Yeah. So all that information is public knowledge. Well, okay, let's watch this little clip. When it came out, it was a very, very big ordeal at the hospitals because all of a sudden people were looking at those heparin syringes. Now, have you ever looked at the heparin syringes for flushes, heparin lock flushes, versus the heparin that's used for clots? It looks similar. They look very, very similar. So things can happen. So this is part of a risk management situation. How can we change things so that the wrong dosage is not given to the wrong patient? Okay? It's a scary thought. It's a scary thought. And I don't know what happened to those nurses, but I'm sure that they were fired and probably lost their license as a result of it. Okay? So these are Sentinel events. You can find a million clips online of Sentinel events. This is a picture of one that was, you can imagine in surgery, that's another thing that happens, is that things get left in the cavity, clamps and scissors and stuff like that. Y'all have been to surgery. You know how it can happen. There's so much going on. There's so many things used. Things get bloody and gushy and you can't see. So there's a million different Sentinel event things that happen every day. And those guidelines that I told you, the things that are considered Sentinel events, are the things that you really need to watch out for. But remember, a Sentinel event is something that can actually occur, but it also may have not resulted in the death, but it had almost occurred. Okay? Alright, let me pass this out. We're getting ready to talk about Miss Josie. This is the paper, and you may remember this from when we went to PEDS. This is the paper that we give out to all of our patients. It's called Code Care. And they use this in some form at the hospital on all the units. What do you think about, you know what Code Care is? Let me remind you what Code Care is. Code Care is given to the patients. They give this paper to the patients and they say, if you ever see something that makes you nervous, or you've told the nurse over and over and over again that your family member is something's wrong with them and they don't listen to you, then you can call Code Care. And what happens is that they call that number, this is from Northeast, but they call that number or whatever number it is at that hospital, and everything stops. Everybody is supposed to group in on that room. Okay, the physician, patient advocate, the nurse, the nursing supervisor, whoever's involved, they're supposed to come together and they are supposed to say, okay, what is it that you see is wrong that we're not hearing? Those of you who are parents, you know your child. You know your child. You know when something's not right. You know when they're not feeling good or when they're sick. Your other family members, your parents or your siblings, who's around them the most? You are. So you're the one that can identify when things start to happen, when things start to go wrong. Okay? I'm going to show you now the Josie King story. And it may make you shed a little tear with Sorrel King. This is Josie. She died when she was 18 months old. And it was from miscommunication started at the nursing level. Okay, and I titled this slide, First Do No Harm, because that's our goal, is to do no harm. Okay? Alright. Events, and remember I said that when you have a Sentinel event, there's a choice. You either go ahead and be a good person and go ahead and report it then, your little hospital, or they end up finding it. But whatever happens, whichever way, following a Sentinel event, you're supposed to do what they call a root cause analysis. And a root cause analysis is going back and saying, what could we have done? What were the events that led up to it? What could we have done differently to make sure that this doesn't happen again? This is a requirement by Joint Commission, whether or not you freely admit to the problem that occurred or they find it on their visit. Whatever the case, whenever a Sentinel event occurs, they require you to do a root cause analysis. Okay? So it doesn't focus on individuals. That's one good thing to remember. In a root cause analysis, you don't put, Aaron Thompson was the one who gave, right, whatever. You don't do that. Okay, so you're not trying to point the finger at somebody. The point of a root cause analysis is looking at the system as a whole and the process as a whole to see what could have been done differently to prevent it from occurring. So does that make sense? Now, whatever happens on the employee level, that's up to the hospital. But as far as Joint Commission is concerned, they don't want to look at individual names, which is a nice thing. Okay, so let's look at our transfusion reaction. Like I said, hopefully you have had experience with your life. Look at it. Okay, so what happened was, if you scan over, and this is the kind of stuff that you're going to be reading when you go for your bachelor's degree. You're going to be reading lots of these articles and figuring out their problem. Okay, so if you skip over to the background, go down to case report. And then it says a blood request for 2 units of packed red blood cells was received for a patient named Jennifer Smith in Ward X, on unit whatever. It was a printed, computerized physician order entry form with the doctor's signature. Okay? The request was accompanied by a blood sample and a labeled vial, which is exactly how it's done in most facilities. We have to type and cross, right? Everybody has to be typed and cross, a blood band applied, and then the order goes to the lab. There was no discrepancy in patient identification details on the label of the sample and the blood requisition. Therefore, the blood requisition was accepted. Okay, everybody with me so far? Okay, and then they go on and they tell how it was cross-matched and all this fun stuff. Okay, nothing unassuming so far is what it says, and the system seems to be perfect in giving safe blood transfusion to the patient. You see that in italics. However, when they call them ward attendants, whenever someone came to collect the blood for the patient the next day, it came to their notice that the blood units had already been collected by another person on the previous day itself. The units were neither found in the refrigerator nor transfused to the patient. In the first instance, it appeared to be a simple case of issue to another patient with the same name, which in itself would have been bad. But it was found that there was only one requisition for a patient with this name, and so that was ruled out. Routine approach would have been to presume that those 2 units were misplaced. Maybe somebody misplaced them or put the label on something else, or they were misplaced somehow. Raise another requisition for 2 units and stop investigating further. However, as the reporting officer was informed and a detailed investigation was initiated, the units were found in another unit, in another ward, after a continued search. One unit had already been transfused uneventfully, thank God, to patient Jennifer with the same first name. And another was still stored in their refrigerator. The compatibility label and compatibility form indicated that these units were indeed meant for the first Jennifer Smith. And the transfusion to patient 2, the second Jennifer, was a mixed transfusion. This was a no harm event, but it would still be considered a Sentinel event, okay, because of the potential harm. You understand that? So you would still have to do a report and a root cause analysis. Okay? As the patient's blood group was A, RH positive, and the blood units were also A, RH positive, but they were lucky in that, weren't they? That was just a, thank God somebody needed A positive blood. If the search was unyielding, this missed transfusion would have gone undetected. And that's one thing I think that's so scary about this, is if they had just stopped and said, oh, well, maybe we just forgot to make them. And they just stopped there. Nobody may have found out that Jennifer Smith's blood was transfused to Jennifer Burke's blood. represents the major chunk of errors represented by a submerged portion of the iceberg, showing that errors are occurring at much higher rates than detected. Okay. The remaining unit, along with the compatibility form, was then taken to the Ward X for transfusion to the one who it was originally meant for. Her relatives, however, informed that she was group AB positive, whereas the blood issued for this patient indicates that she was A positive. Hence, the transfusion was stalled and the blood staff was informed of this discrepancy, again, a near miss. So they had to redo the sample. They redid the sample. Repeat blood sample was then ordered for the patient. It was confirmed to be AB positive, as told by the patient's relatives. So here we have all kinds of mess. Okay? See this? We've got all kinds of mess. What if her family hadn't been there? Okay? I mean, how many, and back to this, how many of you know what your family member's blood type is? I don't. Okay, Candy and Robin. I don't. I have no clue. So would you have been able to tell them, oh, wait, that doesn't look right. She's AB positive. Okay? 2 units of AB positive blood were cross-matched for patient 1, the original Jennifer Smith, and transfused uneventfully. However, according to computer records, the blood group of patient 1 was saved as A positive. So let's say she comes back in again. Maybe she's anemic for some reason, and she has to have frequent blood transfusions. And I typed in crossed her, but they didn't change it in the computer. Okay? The problems yet unsolved were whose blood was there in the pre-transfusion sample. Whose blood was it? And how patient 2, the patient second Jennifer, was admitted in another ward, got involved in the first transfusion. Okay? But she was admitted in a physically and administratively separate ward, and hence the sample collection from this patient was a remote possibility. So it wasn't hers, I don't think. This case was discussed with concerned consultant to identify the source of error and the problem areas in the transfusion chain. The resident doctor who had sent the request and the nursing staff responsible for collection of the sample was called for first-hand information. Now that's something that's really important about a root cause analysis. When you do a root cause analysis, you are supposed to get everybody who was involved together and say, okay, it's kind of like doing a murder investigation, right? You have everybody separately and you say, okay, you tell me what you did. Tell me exactly what steps you did. Okay? Alright. On close scrutiny of the medical records of both patients, it was found that patient 2, Jennifer, needed transfusion during dialysis, and she was physically, temporarily transferred to a dialysis ward at another location. The patient was unconscious, and medical records and her patient number were unavailable at the time of raising requisition. There was no wristband. There's your first problem right there. There was no wristband. The resident doctor searched the hospital information system for that would be the number of the patient with the name Jennifer. Idiot. A blood request was raised. This record actually belonged to Jennifer Smith. The nurse prepared the blood sample label with the information on the requisition form of Jennifer Smith's identification details and collected the blood sample from the second Jennifer. Okay? So here's the problem. She goes to dialysis, Jennifer number 2, okay, goes to dialysis. and she does not have a wristband on. Well, first off, who's at fault? Whoever had her to begin with, right? The nurse who had her to begin with, okay, who admitted her. Is that not one of the first things we're supposed to do? Ask, make sure that it's correct, and slap it on their wrist before. So she goes to dialysis with no wristband. The doctor, the resident who was in dialysis, says, well, I need her number because I need to request a blood transfusion during dialysis. So he types in the system, Jennifer. Well, there could be a million Jennifers. So he pulls up this first Jennifer Smith and writes all of her number and her information, date of birth, and all that stuff on the blood transfusion form. Then they collect blood from the lady in dialysis. So her sample and the other woman's name were put together. Okay? Thus, the pre-transfusion sample request for patient 1 indeed belonged to patient 2. Positive patient identification was admitted in all stages, as the patient was unconscious and wristbands were not available. So, you are the nurse in on this situation. And this is going to happen, especially those of you who go to ICUs and other units where the patients are not alert. How do you identify your patient? Are you just going to lay your hand on their head and say, oh, yes, I know. You're just going to assume that that's the first Jennifer that needed blood in the computer, and so that must be her. What do you do? Huh? They're unconscious. They're not alert. They're not alert. They don't have a name band.
They have a pocketbook or belongings.
Well, who knows them the best? Their family. So you find somebody who knows them, who knows who they are. So the first thing is their family. I don't know that I would trust the unit who didn't put their armband on, because they didn't put their armband on.
How are you going to get dialysis too?
Exactly. Okay.
What if there's no family? What if they're
Then you're going to have to figure out
Can you look
how.
at their bags and wallets if they could
Somehow you're going to have to identify them some way. Okay, but I don't think I would want to be responsible for transfusing blood to somebody I'm not exactly sure. Yeah. Okay. Thus, the blood in the sample tube what belonged to the correct patient that they typed in cross originally and they got A positive. Remember that? That belonged to the right patient. It was the paperwork that the resident filled out that was wrong. Does that make sense? The paperwork was wrong. Okay. The ward attendant had collected blood from the blood center by patient name. Okay. And hence, the error was also not detected at that stage. They consider that the fourth breach right there. Okay. At the time of transfusion again, when they looked at the sample for confirmation of identification, hence the error was not detected because it was the right name or a name that they thought that this woman was. The patient was lucky enough to survive after receiving 1 unit of blood not intended for her, and despite so many errors, as the blood in the pre-transfusion sample sent indeed belonged to her, all these errors would not have come to be noticed if the blood from patient 1 that Jennifer Smith originated was not requested, or if patient 1 was in the same blood group as patient 2. Okay? So do you see the chain of events there? We won't go through the rest of that, but do you see the chain of events there? It started with a simple not having the correct identification on the patient. And how simple does that seem to be? What if you have a patient who's unconscious and you put the wrong armband on them and they go to surgery? And the surgery was meant for somebody else. They can't speak up for themselves. Okay? Alright, this is a root cause analysis of a problem that actually occurred a couple of years ago in our program. Okay? So I want you to get with your partner, whoever you're sitting with, do a test review after I finish this part today. And then tomorrow we'll do our emergency and disaster stuff. Okay? Alright, so do y'all remember this term, breach of care, breach of duty? That's one of those legal terms. When a nurse deviates from a standard of care and a sentinel event occurs, the nurse can be charged with a breach of care or a breach of duty. Okay? So something that was done incorrectly, breach of care, breach of duty means that something was done incorrectly, or maybe it wasn't done, period. So it can involve something that was done incorrectly or something that was not done, period. So how do we prevent getting charged in a sentinel event, in a problem with breach of care, breach of duty? Remaining current in your skills and education. So continuing ed is very, very important. The state requires you to have so many hours of Con Ed when you become a nurse, which is wonderful, but keeping up with that. Hospitals, most facilities, of course, are providing with staff education now, which is nice. So remaining current on your skills and education. Reporting questionable situations. When I was teaching this, I used to use an article that was called whistleblowing, and a lot of people have difficulty whistleblowing. They don't want to get their friend in trouble or their colleague in trouble. You can always report something anonymously or report it as a problem without someone's name if you see that it's a unit-specific problem, not just a person-specific problem. But never be afraid to report because, again, we're dealing with people's lives. Follow the chain of command, making sure that when you're reporting something, you're reporting it correctly, you're reporting it to the right person. Don't skip over people and go to, the next person up. And then document, document, document. I've got this in bold. What did we tell you from the very beginning? If you didn't document it, you didn't do it. Okay? So documenting every part of the nursing process, even the patient's response to the intervention. Medication administration, you're administering pain medicine. What do we have to do?
Sign a
Go back and chart and do an evaluation and chart a response, don't we? That's part of our intervention. So making sure that everything you do is documented. Okay? Everything you do is documented. Now, sentinel events. So let me say this about sentinel events. They are not written in the patient record. They are documented on a separate form. Okay? And a lot of people think, well, that's sneaky because, of course, if it goes to court, then it's not in their record. But it is documented on a separate form. So I'm just saying that that's either here or there. But you need to make sure you know where you're supposed to document when things occur, when an accident does occur. Okay? One thing that I have caught myself doing lately, and again, it's one of those corner things that you forget about, especially now that we've gone to computer settings, and this is that documenting thing. I caught myself doing this the other day, is that when I discharge a patient, I've taken their IV out and I give them their discharge instructions, but there's times when I forget to go back and document that I took the IV out. And I'm the world's worst about that. And so it looks like that they went home with the IV, right? So that's just an example of something just to remember, those processes. Sometimes we have to go back and do things. if we forget about it. Okay. Let's just finish up these last couple slides, and you can take a break before her. Is everybody good?
Yeah.
You have to be. You can't hold it and just watch it up. There's either a test. Okay, professional behaviors. So professional behaviors. So the first thing we have to be is committed to our profession. If you're not committed to being a nurse, then you don't need to be in this profession, because this is a calling. And everybody who is a nurse can tell you that. You have to have a strong work ethic. Consumer education is a very important thing, and then mentoring. So let's briefly look at each of those little things. Okay. All right. So the first thing is commitment to the profession. Commitment to the profession. So, 3 factors associated with professional commitment. A strong belief in and acceptance of the profession's goals and values. You can have a belief in and accept our goals and values by being a professional member of an organization, or a member of a professional organization like the ANA or the Board of Nursing, something like that. So agreeing with their goals and values and ethics. That also plays into number 2, a willingness to exert personal effort on behalf of the profession. I have never been one who's gone to the state level and held up a sign and all that stuff, but a lot of people do. And if you are willing to advocate for nurses and advocate for the profession, I encourage you to do that. Let me say this about the ANA, the American Nurses Association. They are a political organization. They're very politically minded. So before you join, you definitely want to make sure that you read their statements. Being a member of ANA does not mean they will actually back presidential candidates. That's how politically involved they are. But I do want to say that being a member of ANA does not mean that you have to back that precedent or anything. But make sure before you join any nursing organization that you do read what do they stand for. And then the last one, a strong desire to maintain membership in the profession. So again, making sure that you become involved in some way, so you're committed. Now, there are 3 types of commitment. The first type of commitment is called affective or affective commitment. That you truly want to be a nurse. Okay, that's you before you come into the program, or maybe in that first semester, you're excited. It's just really neat. This is what I've chosen to do in my life. I really, truly want to be a nurse. Okay? This, a lot of times, and I've got underneath there the stages of commitment, development. This is in the exploratory stage where you're exploring about the profession. And we've had many students over the years who have come into 111, and halfway through they'll come up to us and say, I've decided I don't want to be a nurse anymore. Okay? Maybe it's that first time they've gone to the hospital and they actually have to touch somebody, and they've just decided, this is not for me. Or the first time they see blood or vomit or whatever, and they just know it's not for them. And we always say, it's okay. It's okay not to want. I'd rather somebody realize that now or at the beginning than get out there and or waste their time. Okay? So that's that exploratory stage. So when you come into the profession, you truly want to be a nurse that just, you watch the Johnson & Johnson commercials and it kind of makes you well up. So, all right, the normative type of commitment. At this point, you feel obligated. Maybe you got a scholarship or a loan to become a nurse. Okay? And how many of you got a hospital scholarship? Jennifer? It's the only one? Nobody else got a hospital scholarship? And what is that? Most of them say you have to work for them for a period of time. Is that what yours says?
Mine didn't.
Yours didn't. Okay, well, a lot of them say that you have to work for the hospital or facility for a period of time to repay the loan or the scholarship or whatever. So you kind of feel obligated at that point. You've invested your money, unless you decide you want to be a Papa John's manager. Or somebody's given you money to go to school. Maybe your mama and daddy said, you're going to go to school. And you're going to be a nurse, period. Well, I've had some students that have been that way too. And then continuance. These are the nurses who have been out there for a very long time. And a lot of them just can't leave. When the economy took a nosedive, there were a lot of nurses who were ready to retire that could not retire because they couldn't leave at that point. That was their only means of support. That was their only means of financial. So loss of income. It affects whether or not they can leave and not become a nurse anymore. And those people, a lot of those people you see that are burned out, or you look at them and you say, you know, it's time to move on to something else. They're not as nice as they used to be. Okay. So the other stages of commitment development, we talked about exploratory, the testing stage. That's when things start to occur. You're already out there, you're working, and then you're like, gosh, do I really want to do this? You know, your first code, your first patient dies, or something happens, and you're like, I'm not sure. I don't know. Do I really want to do this for the rest of my life? Okay. Then you go through a passionate stage where you take the good, remove the bad, and you're just going to make the bad better. Okay. And then there are some nurses who get to the quiet and bored stage. And like I told you yesterday, if you get to the quiet and bored stage, what time is it? It's time to move on to something different. And that's the good thing about nursing, is that you can move to something different. You do not have to be an OR nurse your entire life. You can do something else. And that's the one good thing about nursing. Okay. Work ethics. You have to have work ethics. Some of you are teetering on the attendance and punctuality thing. One thing I do want to tell you is that, and Miss Beaver said this the other day, sweet little Miss Beaver said the other day to me, it might make you kind of step back a minute, that she's not sure if she's going to write a lot of you a recommendation. She's going to have to look at your attendance and your punctuality and how you did in school. You know, she'll look at everything. So, because when they ask us, that's right, you don't want to lie, they ask us on those recommendation forms, did they come to class, were they on time, all those kind of things, how did they dress, yep. Y'all might want to go back and second guess some of your habits. Reliable. Were they reliable? Are you accountable? Are you accountable when you've done something wrong? Do you have enthusiasm or do you have an attitude? Okay, let's talk about a couple of these generational differences. Nurses who are veteran nurses. They were born between 1925 and 1944. Anybody know any veteran nurses out there? Yeah, they're the ones that you see them that are still in the white dresses. Okay. They believe, and I want you to think about this if you were working as a part of a team with these people, okay? You're on your unit, and there are 5 of you working, and there's one of each of these on your unit, okay? The veteran nurse believes in sacrifice and hard work. They believe sacrifice and hard work are rewarded. Okay? The veteran nurse believes that sacrifice and hard work is rewarded. They value loyalty. They respect authority. And They like working with a leader. They want to be in a team with a leader. Okay, somebody takes charge. They are not going to respond to emails. They don't. Miss Collins, now she's more of a baby boomer, but Miss Collins verges on this, or better, and they do not. She is the world's worst. You send her an email and she will not get it because she doesn't open them. I mean, they don't understand that that's part of how people communicate now. So they're more personal. They want you to send them a letter or something like that. Okay. All right, the baby boomer generation. This is my parent generation, baby boomer generation, 45 to 60, born in 1945 to 1960. These people are workaholics. Now, if you're in charge on your unit and you're short a nurse, these are the people that you call. All right, you look at your phone list, and these are the ones that you call because they're the ones that are going to come in. Okay, they're the workaholics. They are very professional, but they do often question authority. Okay. All right, the Generation Xers, which is my generation, 1961 to 1980, Generation X. This generation seeks challenges, very self-directed. They don't have to have someone standing over them. In fact, it drives me insane to have somebody standing over me. Very comfortable with technology because this is when it started being developed. I was telling Ben the other day about my first cell phone. It was a bag phone. Y'all remember bag phones? Oh, I thought I was the bomb. You know, I had a bag phone in high school, and that was the greatest thing. But you know, you had to take it with you. It was like a suitcase. You had it with you everywhere you went. Okay. They expect instant access to information. Expect instant access to information. This generation is the generation that wants control over their own schedule. So when the self-scheduling came out, I thought that was the greatest thing on the planet. You know, that you can actually sit down and you can pick the days that you want instead of, oh, I hated it when I first started working and they would hand you your schedule and this is what you were going to work. And they didn't think about that, you know, their life, you know. So now you can pick your own. I think that's awesome. I love that. Self-scheduling. All right, then the millennials, which is most of you all. Anybody born after 2000 in here? Well, no, because that would only make you 15. All right, the majority of you all are millennials. Okay, you're social butterflies. You're confident. You're collaborative. You thrive on adrenaline. Whereas me, I don't want to be anywhere near an ER. I don't want to be anywhere near the ICU. I don't want any part of that. And cell phones are a necessity for life.
Yes.
Now, Ben's generation, which he was born in 2005, you know, they're even worse with technology. You know, they have iPads at school now. They're more of this handwriting anything, you know. That's how they're doing everything now. So I think their generation is going to be even more. But when you're looking at your staff on your unit, these are the people, this is how you identify people. You remember I said that the baby boomers are who you call to work whenever there's somebody out, sick. They're the ones who are going to come. It's not going to be the millennials. They're not going to come in on their day off because they're social. Okay? And I say that jokingly, but it's the truth. They're the ones who have, you know, they're going out and doing all kinds of fun stuff, and they're not the ones who are working. needing to work. The Generation X, my generation, has to work because we're poor, because we were never taught how to save money. So those are the people. That's how you identify these people in the units. And how do you communicate? Can you, if you're in charge of sending out a staff email, or the veterans are not going to look at their email. They're going to want to know where the computer is. They're not going to have any idea. So you've got to figure out, how do you get the information out to the generation? Does this not also impact your teaching of your patients? Okay. When I have a new onset diabetic kid, one of my favorite things to do is to take their cell phone and program apps in for them for diabetes education, because that's what they've got with them, right? They've got the telephone with them, or the cell phone with them, and it's always a smartphone. So I can program the restaurant app with all the carb counting and stuff in it, and they have it with them. But Shane's mom, for example, now my mom's more technology savvy, but Shane's mom has just a regular old flip phone. I couldn't send her a picture if I wanted to, because she doesn't know how to open it if she did. So those people, if you're trying to teach them something, technology is not going to be the way to go. They're going to be more, hand me a piece of paper. Right? You hand somebody a Ben's generation a piece of paper, and they're not going to know what it is. Okay? So it goes back, that's how you teach. Alright, let's talk about teaching real quick. Now, I think you've already been to this website with someone else. I'm not sure, because I thought I heard somebody talking about it, but we're going to watch it really quickly again. We're going to talk about literacy, health literacy. So when we are teaching our patients, because that's part of our responsibility as a nurse, is client education. How best do they learn? And health literacy is one of the biggest problems in the hospital today. Okay? People, what is the average average education level of your patients? You know,
6th grade.
It's 5th grade. Well, it used to be 4th grade. Now it's 5th grade education. Okay, so when we are assessing them and we're looking at, first off, look at what generation they are. We just talked about that. And then try to tailor their learning to how literate they are. How ready are they to learn? If you're trying to teach someone how to take care of a new stump, they had a below-the-knee amputation, and you're trying to teach them how to take care of that stump, the day after surgery is probably not going to be the time that they're going to learn the best. What do you think? No. But you've also got to remember, are they able to learn? You know, a lot of older generation, how many of you had grandparents that didn't make it through high school? Couldn't read? I've told you the story, I think, of, I know I told it to the freshmen. Did I tell you about the 17-year-old girl and guy that we had last summer who came in? I'll tell you anyway. Just listen to it again. We had a teenage girl who was admitted to the hospital last summer. She and her boyfriend had come down from somewhere to watch a race. And she was technically still at her age, so she was admitted to our unit. She had a horrible pyelonephritis. So she was admitted to the unit, and her boyfriend was the only one with her at the time. So we were asking him to fill out these paperwork, and he could not read or write at the age of 17. He could not read or write. So do not assume, right, that just because they're young and hip, right, going to the race on it, that's hip, that they can read and write. Don't assume that. They can't. So you've got to be very, very careful about that. So also looking at their health beliefs and health practices. Okay? Alright, so let's look at this real quick, because I think this is sad. I know you've probably seen this before, so bear with me and just watch it again.
I was sick a lot. I was sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. And when they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
I can't read this. Well, I guess the doctor gave it to me, so it's okay for me to take it.
When your children have fever, what do you usually give them? Motrin or Tylenol. Normally Motrin, because that's what my doctor says. How old is your daughter? She is 4. She's 4. Okay. I would
This is very
give
scary
her
to me as a teacher.
4 to 5 tablespoons and a half.
One capsule.
That's right. One capsule.
One capsule. I don't know what this is. Twice daily.
Okay. So how would you take this?
When I see it's not on there, tell you how to take it. It says take it twice daily, but it don't say what time to take it.
Do you know what hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension, and I've been taking care of that for a long time.
Second grade reading.
Hyper. Hyper.
Like you're hyper? What does being hyper mean to you?
That's or you can't be still. You always got to be doing something.
Do you think I think you're hyper? You have hypertension?
I don't know. That's what I consider it.
Okay.
It being, you know.
But you know you have high blood pressure. Okay, but hypertension doesn't mean the same to you. So if I ask you if you have hypertension, you're going to just think I think you're jumping around on the chair or something like that. Something different.
Just being hyper, you know.
Okay. All right. Well, I haven't done a very good job teaching you what hypertension is, because I think you take that medicine for your hypertension, and that's one of the things that I try to work with you on is your blood pressure. And high blood pressure and hypertension, to us, is the same thing.
The same thing.
Yeah.
I have a small breakfast, and then I take my pills. I usually take 16 every morning. Sometimes it's difficult for me to take these pills because if they say one tablet twice daily, I don't know if they're talking take one in the morning, one in the evening, or take one in the afternoon or one in the evening. So usually what I do is take 2 of them in the morning. And this way I know I have them.
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office, and mostly, if you realize, first thing you're going to have to do if that's your first visit is fill out a form. Your heart beats real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, well, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity. So I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it.
Jesus. What do you think?
She wouldn't have hysterectomy done.
It is sad, and the problem is that they're not going to admit it to you. And you heard them say that over and over and over again. They're not going to admit it to you because they don't want to look stupid, right? So if you tell them to sign here, they're going to sign. Now, what can you do to ensure sure that you know that they know what the paper said.
Return them, return them.
What questions do you have? But they may say, none. Can you explain it back to me? Right. Can you tell me what this says, or can you explain it back to me? Okay. Still, they may not admit to you that they can't read it. They may say, "Oh, honey, I don't have my glasses with me." That's a big red flag. If you've got somebody that says they don't have their glasses with them, that's one of those things that you should focus in on, because that's probably them saying underneath it all that they can't read it. Okay? So very, very important to focus on this. I'm not going to spend a whole lot of time talking about it because you have talked about it before, but it is part of our professional role as a nurse to make sure that our consumers know what they're learning. And then the last part of our role as our nurse when you graduate is staff education. That's what we're doing with our projects, right? This is staff education projects. We are, after you graduate, you're going to be considered an educator and a facilitator of learning, of staff learning, of your own learning, okay? So you have to be able to teach someone else or encourage someone else by doing staff education presentations. There are a lot of different types of staff education out there. Of course, it begins in orientation. The second part is in-service training, and that's what you're doing. And then continuing education. In-services are focused on improving your day-to-day behaviors. It's the things that you're doing with your little presentations. What can we do differently on our unit to make our process better? Continuing education is what you're going to be required to do by the state. Continuing education is building upon your expertise level. So it's taking you where you are now and making you an even more well-rounded nurse. That's getting your bachelor's degree, going for advanced certifications, those kind of things. Those are continuing education. Okay? So they're usually the difference between in-service training and Con Ed is that Con Ed gives you hours. So that's one way you can always tell. They'll say this is for 6 contact hours or whatever. So that's how you tell what that is. So staff education, and part of that is mentoring the new nurse. And I want you to remember honestly, and everybody says this to me, I remember how much trouble you had getting preceptors when I get out there, Miss Warren. I'll be a preceptor for you. And I really do want you to remember that. Now, I'm not sure. I think the time is coming, honestly, where we're not going to have preceptorship anymore. Because it's just too much. The good thing is that when we retain numbers like you all, it's even harder to find nurses out there that are willing or able to do preceptorship. But if somebody ever asks you to precept someone, be honored, because they have faith in you. They have faith in your abilities, that you are able to be a preceptor. And remember how hard it is to mentor someone. Set goals with them. One thing that I'm going to make you do is to set a goal, a daily goal, when you're with your preceptor. What do you want to accomplish today? I want to get better at delegating tasks, or I want to get better at skills, or whatever it is. Set a goal with your mentee so that they know what to work towards, right? You always have to have a goal. It's like our nursing care plans, right? We have to have a goal, and then we do interventions to get us to that point. If you set a goal of being a better delegator, but you don't implement any delegation strategies, then, well, you haven't met your goal. So it's the same thing when you're working with a mentee and you're a mentor. But it's very important to remember where you've been so that you can make a difference in somebody else's life. Okay? Alright, so that's all about being a nurse in today's world. There's a whole lot more.